Hello, and welcome to Healthy Kingston, a health promotion and wellness program of the Kingston Board of Health. I'm Janet Wade, your host. Many of us are caring for loved ones who are quite ill, possibly near death. It's a very overwhelming process. And we've also heard the terms palliative care and hospice care used quite frequently and interchangeably. So I've asked the guest to come in today, who's had a tremendous amount of experience in these areas, to clarify for us what is hospice care, what is palliative care, when should they be used, under what circumstances, and what do they actually provide. So I would like to introduce our guest, Dr. Deb Kylander. Thank you so much for being here.
Thanks for having me.
A local woman, born and raised in Duxbury and back in Duxbury now. She attended UMass and graduated from UMass Medical School and did a fellowship in geriatric care. She came back this way. She was in Pennsylvania then. She came back this way and worked for the Primary Care Associates with Beth Israel Deaconess, and then became certified in hospice and palliative care. And in October of 2024, she became the director of Cranberry Hospice here in Plymouth. So thank you so much for being here. You are definitely an authority, and we feel very fortunate to have you here and your expertise.
Thank you.
And thank you for all you do. I don't know anyone, myself included, who hasn't been impressed by hospice and palliative care staff. They just provide a tremendous service for those of us who are trying to do well by our loved ones and very upset at the time and need direction and confidence and support. So thank you and your staff for all you do.
Thank you.
So with all that said, what is palliative care?
So that's a great question, and it's a topic that I think a lot of people are really confused about. So palliative care basically just means providing extra support with symptom management, focusing on goals of care for anyone who has serious illness. So it's just really focusing on what people need so that they can live the best that they can while managing their chronic illness.
When you mention chronic illness, can you give us the suggestions? Everyone automatically thinks cancer, but this incorporates a lot of illnesses.
So it can really be anything. I mean, chronic serious illness can be anything from heart disease with heart failure, chronic obstructive pulmonary disease, or respiratory disease. It could be related to dementia. It could be related to just generalized weakness from a number of different things. Of course, palliative care is associated with cancer treatment as well. And I think the biggest thing that people really need to know the difference between palliative and hospice is that palliative is not just for end of life. Palliative treatment and support can be helpful for anyone at any stage of their illness, and even if they're expected to recover from that illness.
Mm-hmm. It's interesting. I did some research on this, and there was an article in the American Journal of Medicine that stated that people who have had palliative care live longer and better quality of life, which I thought was interesting.
Yeah, I mean, it is interesting when you think about it. There have been a number of studies. Palliative care as a field of medicine is relatively new, and so there's a lot of research that's being put forward. There was a landmark study done by one of the oncologists at Dana-Farber talking about palliative care involvement for people who are initially diagnosed with stage 4 lung cancer, which is lung cancer that has spread. Mm-hmm. And those patients who received palliative care involvement actually did have better outcomes and had better quality of life. So it's pretty impressive. And I think it really is because you're kind of stopping and taking some time with someone to put the diagnosis aside and to focus on the person. And that's really what it's about.
Sure, and everybody's different.
Yeah.
So if you could kind of take us through the process. So the family member will come into your office and you speak with them about palliative care and what's the nuts and bolts of palliative care?
So if, say, somebody's primary care physician or anyone on their team is seeing them and saying, it might be helpful to have palliative care involvement. First of all, some people say, oh, no, I don't want that, because they think that's hospice. And so it's nice to educate everyone that they're suggesting that just because maybe this person or this patient or this loved one has had several hospitalizations related to their diagnosis. Maybe they have been falling a lot. Maybe they've been struggling. And so someone's recognizing that there's a need for additional support. So it's not a bad thing if someone says, hey, it'd be great to get palliative care involved. And so what we do is we'll reach out, and that patient and family then will be seen by either a physician or a nurse practitioner in general. All teams are different. And we'll just sort of sit down and talk with them about how they're doing, talk about how their illness is affecting them, talk about what they're looking forward to, what they're worried about, and really kind of come up with a plan that involves many different dimensions. So one thing that I do is, I review all aspects of their daily life and what they're having a hard time with and what's frustrating. I'll review their medications and say, what? This medication may not be helping you now. Let's talk about it. Or this medication actually could be hurting you and causing other problems. Let's talk about it. In medication management, we don't usurp any other providers. This is all done in conjunction with other specialists and other people involved in the care. But mostly just make suggestions like, hey, I saw this person, we reviewed medications. Also, my favorite thing is to do house call and to be able to say, hey, show me your house, see the pictures on the wall, see how they get around, see where they're sleeping, see where they're going to the bathroom, not, obviously with them, but, just looking at how people's lives are and how they're getting through them and trying to figure out a plan that will help that be easier or better.
So they don't have to drop their primary care physician,
absolutely
or
not.
cardiologist, or whoever else might be on their team.
So it's just we call it an extra layer of care.
Okay.
And in this area, really, the most of the palliative care consults are done by either a physician or nurse practitioner. Some palliative programs might additionally have a social worker, but teams generally aren't as comprehensive as I would like them to be. So I'm hoping that's something that we can all work towards in the future, because I think, a team approach to palliative care is really important. In what I do is I will often gather the resources that they have in place and look out for other resources that we can work on getting them. Because as one person, it's very difficult to make a huge impact. You can make suggestions, but people need a lot of different things to make their life feel better. So
you speak about a team, but in actuality, the team is you and or a nurse practitioner that will go out.
Usually, and sometimes there may be a social worker or maybe a nurse.
Okay.
Yeah, or somebody who will contact them by phone, because a lot, of course, is done virtually now.
Okay. Oh, really?
So, yeah.
What about home health care?
Yeah, so home health care is not considered part of a palliative team, but a suggestion might be made by one of us going to the home to say, you'd probably benefit from the visiting nurses coming in and offering extra assist. So just for example, I saw someone last week as an initial consult in the home, an older man with heart failure. And I said, I think it'd be great if we could get visiting nurses in here to provide some extra nursing care, and also to do some physical and occupational therapy, and also have a social worker review what other options might be available. So that's how I work with the VNA. I then reach out to the primary and say, hey, I saw your patient. These are my recommendations, so that they're on board and aware as well.
So who reaches out to the VNA or home health? Do you do
so
that?
that's it's usually done by both. Sometimes I'll say I can do it, or if it's easier, you can do it. In general, I like the primary to do it so that the primary is still involved. And in charge of that care.
Okay.
Yep.
Got that. How do you see this as helpful to the family?
So I think, really, again, it can be really overwhelming and really frustrating to be sick in our healthcare system. I think what happens is people may go to the hospital, or they may go see their specialist, or they may go somewhere. And, the way it is with most of our visits, it's 15 minutes. And most things really can't be efficiently or properly addressed in 15 minutes. Mm-hmm. And so, the specialist will have knowledge of an organ system, but sometimes how that affects the person as a whole, it's difficult to bring that into that visit. Also with the primary care physicians. I think also, I know this for many people is that the offices are busy. So you might see one person for primary care, that you might see your physician or your nurse practitioner, and the next visit they're not available, so you might see someone else. Mm-hmm. So it's a way to say, okay, wait a second. Let's stop this snowball from getting bigger and bigger, and let's try and stop, take some time, and look at this everything that's going on with this one person, mm-hmm. and try to figure out, where are we going? Where do we want to go? And what's the best way to get there? And thankfully, we have a little bit more time in our visits. Right. And so a lot of it is time, and a lot of it is really specific training to identify those things that are important for that particular person. So
it sounds wonderful. I would think it would be a godsend for any family to know that there's someone who can see the big picture and is over everything and know who's talking. A's talking to B, and talking to C, and so it's great for continuity of care and keeping everything tight and inclusive.
Yeah, I think that's really true. I think it's great for families. It's great for patients. And honestly, it's also, I work very closely with a lot of primary care physicians in the area. And it's really great for them. I have worked very closely with many of them for a long time. And, they'll reach out to me and say, I'm seeing this patient in the office. This is what I'm seeing. Could you go out and do a house call, see what's going on, see what else I'm missing, see what else you might recommend. So, again, it's a collaborative involvement. It's not to take anything over. And it's not because the primary care physicians or the specialists aren't getting to the meat of what they need to get to. It's just sometimes you need somebody to just, again, see the whole picture. And to help assist in that care.
Right. So. Okay. So how is this paid for? What is the kind of coverage people need to be able to have palliative care?
Yeah, so palliative care is paid for by Medicare and most insurances on a fee-for-service basis. So that house call or that palliative visit, whether it be in the home or in an office, is going to be paid for just like a visit to any of your other medical providers. It's paid for, basically it's the 80-20. Sometimes there could be a copay, sometimes not. In my experience, there hasn't been a copay for my services. So it's not paid for out of pocket. It is paid for by insurance.
However, mm-hmm. if you want to bring in, as we were speaking before the program, you want to bring in VNA, a home health nurse, or not VNA, but a home health nurse, an aide to help. That's on the family to provide that.
Yeah, so palliative services are paid for primarily by fee-for-service, unless there's a contract with a bigger insurer. Other needs, so again, visiting nursing agency might be able to provide support for a period of time. But if additional support is needed, say a family and patient need a caregiver a couple hours a week or a couple hours a day, that is generally paid for out of pocket. It's private pay, unless there are resources available usually through Medicaid. And so, Yeah, so palliative care is not able to provide, extra care in the home. And that's a really good point, because I think sometimes people think that I'm going to get palliative care and I'm going to get this with the package. And that is not part of the package. Okay. Yeah.
All right. Well, I personally have a lot clearer picture of palliative care now. Hospice. So how do you define hospice care?
Sure. So, I mean, hospice, when you think about palliative care as being, a specialty that provides an extra layer of care for symptom management and reviewing goals of care, hospice is part of palliative care, only it's specifically for the end of life. So it's a lot more defined in terms of end of life. Usually, in order to be eligible for hospice, there has to be a reasonable expectation of less than 6 months to live, because we don't really have a crystal ball. Sometimes we don't know when that'll be. And so some people live on hospice services for longer than 6 months, sometimes a year, sometimes a year and a half. And after the 6 months period, those patients are evaluated on an every 2-month basis to see if they're still eligible for hospice services. Certainly, there are people who come on to hospice services with the expectation that they may be dying, and that could be in weeks to months. But for whatever reason, they stabilize, and sometimes people do improve. They get a little bit stronger, they start to eat a little bit better, whatever it was that made them acutely ill seems to be at bay. And so sometimes we reevaluate and we say, you know what, it looks like you're doing pretty well. You may benefit from other things outside of the hospice realm. Mm-hmm. For example, getting physical therapy or occupational therapy. Maybe someone's gotten better to the point that they want to try and get stronger. And so that's a way to focus on the sort of the next phase. And so those people might decide to be discharged from hospice. Mm-hmm. But in general, anyone who has a reasonable expectation of less than 6 months to live with any number of serious illnesses. The usual are the ones that we talked about with palliative care. The ones that we usually see are patients with cancer, patients with end-stage dementia, heart failure, end-stage lung disease. We see a lot of patients who have Parkinson's disease, some patients with ALS, and then some patients who can really best be described as getting older and frail. And there's a number of things that are the reason for that, but it doesn't boil down to one thing. And so, and sometimes we'll see that with, sometimes we'll say, okay, this patient is they're not doing well. It seems like they may be getting closer to the end of life. And the things that we see are, they used to be able to get up and walk, and now they're bedbound. They used to be, they've used to have a great appetite, and now they've lost 20 pounds in the past 4 months. Mm-hmm. Getting more confused, having more problems. Those are things that we might see, but we can't put a real finger on it. Those people are also hospice appropriate if that's within their goals of care. Okay. And so that's the other thing that I have to say is hospice is a Medicare benefit. It's paid for by Medicare. And it's for people who qualify for hospice based upon their end of life prognosis and their diseases, but also if that's in line with their goals of care. Mm-hmm. There are many people who say, nope, you know what? I want to continue going to the hospital and having more aggressive care, in which case that is totally available, but that's not generally hospice.
Okay. What are the nuts and bolts of hospice?
Sure. Yeah, so paid for on that hospice Medicare benefit are visits from nursing, home health aides, usually 2 or 3 times a week. Sometimes it can be more, but it's never on a basis of several hours a day. Physician or nurse practitioner visits, also any medication related to their diagnosis, oxygen if needed, hospital bed, any medical equipment like a hospital bed, wheelchair, walker, recliner, And then a lot of sort of care supplies, like, if you need an adult Depends or absorbable pant, that's usually paid for, as well as volunteer services, which are amazing, bereavement services after death, and also social work. So there's a great team that's available.
Well, that's
and I'm
say.
forgetting chaplain. I'm so sorry. And chaplain.
Right.
So
so there's a team that actually looks at the person
absolutely
and what their
provides
needs are and
provides care for all different dimensions. So nursing is looking out for their medical needs. Social work is making sure that all of their needs and their family needs are in place. Being there with them for discussions. Spiritual support through chaplaincy, I can't emphasize enough. This is not something that we all go through often. And for us personally, in the dying process, this is something that we go through once. And we've never done it before. And I think sometimes people really benefit from the guidance of chaplain, just to review sort of end-of-life questions like, what's happening? Where is this going? And they're experts in that, and they're amazing. So the whole team really can bring just so much sort of wraparound care to someone who's in that dying process.
Right.
What hospice isn't able to cover, which I think is sometimes misunderstood and sometimes confused in the same way that palliative, is that hospice can provide 24/7 care in the home. When someone is going home with hospice and it's their goal to live at home until the day that they die at home, any additional care that they need on a regular basis is usually provided by families, friends, or private pay support. And that's something to remember. And in some ways can be a luxury for some people. There are also, hospice is also provided in the assisted living setting, also in long-term care setting, and then there are also hospice homes that some people elect to go to at the end of life.
And you mentioned to me, I asked you about Cranberry Hospice and what your catchment area is. So if you could speak to that.
Sure. So so I'm the medical director of Cranberry Hospice, and actually Cranberry Hospice is a department of Beth Israel Plymouth, a really strong, lengthy relationship. Something that I've learned in the past year and a half since I've been medical director is that Cranberry Hospice was actually established in the mid-'80s before Medicare even started the hospice benefit. Started by one of the oncologists at the time, Dr. Hoxton, who worked at the Cancer Center. So Cranberry's been around for a long time as a not-for-profit hospice. Our relationship with Jordan Hospital started a little bit later. And then we have continued that relationship with Beth Israel Plymouth, and also work closely with the Beth Israel Leahy at Home Hospice and Palliative Care Program. So our Cranberry Hospice really provides services pretty much within the lines of Plymouth County. So usually up to and including the bridge on the Cave. We have had a few patients that we see over the bridge, but as everyone who lives around here knows, getting across the bridge, especially in the summer, can take a very long time.
Right.
And one of the things that we pride ourselves on is being able to provide 24/7 care. And if that 24/7 care, nursing visits, on-call visits, can't get to that patient, then we're not providing very good care. So we basically will see patients out into the East Bridgewater area up until Hanover and over to Scituate, and then everything in between. So
good for you. Well, a tremendous amount of information on both palliative care and hospice. I've certainly learned a lot. So if you could give a takeaway from this, what would you want people to remember from your remarks between the two?
So, I think it's really important to, palliative care has gotten a lot of press and a lot of buzz, and I think that's fantastic. I think for me, it's just really important to know that palliative care involvement is great and really important. but that it doesn't mean that a whole group of people are going to be providing care in the home. Same with hospice. If a person's goal is to be able to live the rest of their life at home and to be able to die at home or in their place of residence, I wouldn't do that without hospice involvement. The people who work in hospice are amazing. They're very good at what they do, and they provide a tremendous amount of support. And so I just think it's important that people be aware of the benefits of both palliative care and hospice, and also that there are some limitations. And sometimes it's not easy, and that hospice can help guide you in that process and can be there for extra support. But sometimes you have to know that what you're getting in for. So
absolutely.
Yeah.
And you certainly let us know that today.
Wow.
Thank you so much.
Thank you so much for having me.
Thank you so much for all you do for our
Thank
community and your team as well. All right. So take care, stay happy, stay healthy. We'll see you next time.